you say something about 65?
Age 65 is the upper limit. We'd like to start a transplant evaluation before you turn 65. There's some people who are right there, skidding in right at 65, and if they've got not a lot of other issues, they're exercising and they're in pretty good shape, then we'll take it to the committee. We'll take it to the committee to get it approved to evaluate. We don't do children. The youngest we do, I think the youngest we've done recently was 17. Okay? And the body mass index, which is the bane of everybody, that is your height and your weight, and 30 is the upper. A lot of times people will be getting referred when their body mass index is high, and then we get them working on getting it down. We can't list you at UVA until your body mass index is below 30. And it has to be above 18. So a lot of people really struggle to put weight on, so sometimes we have to help them with that with the peg. You have to be able to walk at least 500 feet during your 6-minute walk. So, and that's with a walker and everything. You know, when you get your transplant at UVA, we're a small center, you have to be able to get up and go with it. Okay? The whole idea is to get that transplant, get that tube out, get up and walk. That's why I say we're ambulatory transplant, walking and talking. There's lots of risks for transplant. This is not a fix. This is serious. This is a big decision. And I had a roller coaster in my original, I think it's on another slide, but it is a roller coaster. And I put a few of the risks. There's a lot more risks. Number one is you can die. Number two, all the rest of it. And so, you know, there's a lot of behavioral, there's a lot of clinical and medical outcomes that are difficult. It doesn't fix it. You kind of change one set of problems for another. Everybody from UVA's heard us all say that. I hope when people walk in, they never need a transplant. Because if you can do something else, sometimes just get yourself into shape, sometimes getting pulmonary rehab, losing weight, getting a few other things fixed. Sometimes the medical course of what you're doing is actually makes more sense than a transplant. But that's part of what your team, no matter where you are, helps you kind of figure that out. So here's the deal, referral. Timing is a big deal. A lot of times people get referred too late. And there's a time where you want to get referred and at least get known, get your case started. At least, I say, on the radar. A lot of times we'll have people referred and it's way too early, but at least we'll follow them. And then if they turn a corner and they get really sick, we can either get them listed or we can get them where they need to go. And this was something one of our patients said, they just need to get their whole head wrapped around having somebody else's lungs. And it's an emotional thing, you know, but truly, truly, it is a gift. If you can even believe how much, what a gift you're giving some family by letting their loved ones' lungs help you. Or help one of your family members. It's a different kind of way to think about it. Getting in early, if you get in too late, it's too late to do everything. It's a big workup, there's a lot of education, there's a lot of things to do. And the other thing is, you can be listed at multiple centers. It's like you can walk into Walmart and you can walk into Sam's and what are the other big centers? You can go to different places. You just have to be able to have the support system and the finances. I have many patients that are listed at UVA and at another center as well. And the specifics of that I'll talk about a little bit later on. And I just said it's a job, it's a hard job. People who go through the whole evaluation and then just the whole transplant, it's a very big job, it's a big commitment. How are we doing? Does everybody understand everything? Can you hear me better? Can you hear me? Okay. Not everybody, it's not for everybody. And so some people just decide this is not what I want to do for many reasons. They make a decision not to go through it. But the whole idea is that you want to optimize the medical therapy, your medicines, and make sure you're in good shape and you have the weight off. You want to make sure you do all of that before you're really thinking seriously about transplant. And it's really, you don't do a transplant for your grandkids or your kids or your husband. It's your decision. And I think a lot of times when people decide, they come to us and they decide they don't want to do it, but they're doing it for my kids or for my grandkids, and they're not the one that has to go through it. So really, people have a lot of soul searching to do for that. So that's why I said it's your choice to refuse, and that's any time. I've had patients on the list. I've actually called somebody in, and while they were driving in, they decided they didn't want to have a transplant. We hope never to hit that situation because lungs are a precious commodity, and luckily we were able to offer them to somebody else. But those decisions, it doesn't matter though, even though we didn't like the way that happened, that person was being very honest. And so that's what it ultimately is about. And you have to look about the risk versus the benefit. I know these are really stale slides. I have these really good pictures. They're like on this little thumb drive over here, and it looks like Japanese. And I think there's something else on there, I don't know. But so I apologize, they're a little bit stale. But we'll talk about the risk and the benefit of a transplant. It really gets down to about quality of life. When people, I say, what do you want to do? What did you do a year ago or 2 years ago? Walk your dog without oxygen, get down with my grandkids, go to the beach, get in the water. I want to plant my garden. We have a lot of farmers. There's a lot of people in West Virginia who live on hills. I just want to walk up the hills to see my grandkids. Not everything's flat like here. We have a lot of people that live up in the hills. So, you have to kind of weigh, but everybody has their own story and their own reasons, and they're all good. Those are all good reasons. So every center has different selection criteria, and it's, of course there's like the clinical things, but the things that are absolute contraindications would be things like HIV, hepatitis C. I say cancer, like lung cancer. If you have a cancer, you have to be 5 years out from it, and it has to be cleared. Not chronic high-dose steroids, it could be over 20 milligrams. Yeah.
You have CLL.
What's that?
Yeah, I can't pronounce all that stuff. Chronic lymphocytic leukemia.
You have to, every different case, you have to see what it is.
Okay.
What it is, because ultimately you don't want to have cancer and then go on immunosuppression that lowers your immune system, and then you get the cancer and go through the full lung transplant and then die of cancer. Which is why it's just so important. Like this book right here, this is a great book. No matter whether you do lung transplant or not, keeping up with all those preventative screenings, colonoscopies, breast exam, pelvic exam, all of that stuff, prostate exam, they are so important no matter if you go down that road or not. Other things like severe osteoporosis. Post-transplant medications are hard on your bones. So the whole idea is to be able to get up and walk. So when you're talking about Symbicort, getting those bone density scans, making sure you get your vitamin D, doing all of those questions are good. There's a lot of stomach, I think, I just learned one, I'm forgetting what it is, it was one of the PPIs. Pepsid's the best thing to have, for your stomach. I forgot what the other one is right now. What's the other one? Nexium? Yeah, I think Nexium interferes with absorption of vitamin D. Prevacid. What it is? Yeah, okay. See? And ask your pharmacist, make them earn that money. No tobacco, no nicotine. Yeah.
I noticed diabetes is not on that list.
That's not if it's well controlled diabetes, almost everybody has diabetes because they've been on steroids. So, it's like, that's what came first, So type 1 diabetes is a little bit different because it's brittle. but I hardly have any patients that don't have type 2 or are going to get it.
And it's okay.
As long as it's under control, and as long as your kidneys are working. Okay. Tobacco, nicotine, that's cigarettes, it's lozenges, it's gum, all that stuff. Nicotine has to be out of your system because people who are even exposed to secondhand, yeah.
Chewing gum?
Chewing gum, yeah, no nicotine. This is at UVA, I don't know a transplant center right now that doesn't do a nicotine. And the reason is because it's horrible to see a post-transplant patient go back and smoke.
Yeah.
And that's a hard thing. So our criteria got really tough with that one. To go look at your donor family and be smoking, that's how you have to kind of visualize it. That's kind of a tough message, but that's a good way to kind of think about it. And you know, I'm not judging that at all. You know, I'm just saying that's our guidelines. There's a lot of people, they don't have anything else, they're not a candidate, and that gum is important to them. And of course, alcohol or drug use. I put this in because I keep saying it's an option, and some people start an evaluation and they stop. But their long days, it's a hard job. Like I said before, you have to have your family. You have to have your family with you. You have to have your support system, and everybody needs to be active. No matter where you go, that has to happen. There's so much information, I can't even remember it all. There is a list of tests that you have to do, but basically, they're looking at you head to toe. We're looking at your exercise capacity, your upper and your lower body, how strong you are, your breathing test. We're looking at your x-rays, CAT scans, trying to rule out any kind of nodules or lung disease. X-rays to look and see how big your lungs are. Perfusion scans to see which lung is least perfused, because that might ultimately decide what kind of lung transplant you get. Right. Thank you, Leah. That one almost brought me down to my knees. All of these things are kind of looking at your candidacy, looking at what kind of a candidate, how you're going to do post-transplant, or looking to see if there's things that you need to do to get yourself in shape. Sometimes you might not have like the best test outcomes